So we're just going to talk about trying to stop progression in chronic kidney disease, kind of a hard thing to do. So what we're going to try to do is just looking at chronic kidney disease and seeing if we can find it a little bit earlier than what we normally do. And the second thing's, what are we going to do to try to slow progression? So we're going to talk about bicarbonate, some SGLT2 inhibitors, and really just trying to stop AKI in patients with chronic kidney disease. Okay, so just a little bit about chronic kidney disease. There are 37 million Americans that have chronic kidney disease. There are 10,000 nephrologists. So for each nephrologist, there are 3,700 people with chronic kidney disease. So I think that the message with that, you guys, is a lot of the times, if you're primary care, you're going to be seeing most of these people and then referring us some of these people, but we can't possibly see all of these people. It costs Medicare $100 billion per year. That, it's an increased risk, of course, of dialysis, but really most of our patients never get to dialysis. They die from cardiovascular mortality. If you're a diabetic and you have CKD, your mortality is sixfold if you don't have CKD. So really, CKD is what really just accelerates your mortality with diabetes. And it just disproportionately affects underrepresented minorities. So African Americans, there's this APOL1 gene. There must be these other genetic things that cause or that are associated with chronic kidney disease, and we just haven't identified them yet. So yes, this is a little bit about just checking the urine albumin to creatinine ratio, okay? And this is just a large cohort study. This is your adjusted risk of having dialysis, and it's a logarithmic scale here. So here's 8,000. And here's eGFR. It makes sense. The lower your GFR, of course, the greater your chance of having end-stage renal disease. But what I really didn't know is how much it's modified by your urine albumin to creatinine ratio. So what this thing is saying is that if your GFR is 120, but you have 301 milligrams per gram of albumin, you have the same chance of being on dialysis as someone that's as low as 40 with no albuminuria, 29 milligrams per gram of albuminuria. And I just didn't think, I knew protein was something, but I just didn't think albuminuria was that important a risk factor. And it really, truly is. So it's something that, if you guys are sending people, if we're trying to prognosticate, we really should try to get this albumin to creatinine ratio, okay? So just, not only is it important for end-stage renal disease, but this is just, again, a cohort of almost 25,000 people. And they're really looking at cardiovascular mortality, okay? So here's our traditional risk factors: smoking, cholesterol, blood pressure, diabetes. And basically, the more to the left you are, the more important that is in determining your cardiovascular mortality, okay? So when they looked at GFR, albumin to creatinine ratio, and both, you can really see that this is a huge predictor of cardiovascular mortality, okay? So getting the albumin to creatinine ratio, that spot sample for CKD patients, really an important prognostic sign for us, both for not just dialysis, but cardiovascular mortality. Okay, so a little bit about, who's at risk. So we know diabetics, hypertensive, those with cardiovascular disease, those that have had history of AKI, and people with family history. It makes sense. As far as other demographic factors, people over 60, and again, minorities. So for me, you guys, my uncle's on dialysis. I'm 59.99 years old, and I'm Asian. So that gives me 3 risk factors for chronic kidney disease, okay? All right, so just a little bit about how we detect it. So, we talked about this albumin to creatinine ratio, okay, and how it's a risk factor, and how it might actually crop up before you see a change in the serum creatinine or the eGFR. And this is just a little bit of a picture here, looking at, okay, let's say we have 100% of our nephrons, and here's a GFR of something over 100, okay? But at 100% of your nephrons, you can actually really crank up your GFR. You've got this, what they call functional reserve. You can hit up to 180, okay? Now, what happens is that at 50, okay, at 50% of your functioning nephrons, it's not that your GFR is necessarily going to go to 50, but you also have this ability to kind of rev up those remaining nephrons so that your creatinine looks okay, but really you've lost a lot of nephrons. So The creatinine, again, is not the best sign. When we've lost, or when we have a higher serum creatinine, really we might have lost a lot of nephrons by that time. Okay, so what do we look for in chronic kidney disease? So just, it makes sense. We want to look for systemic symptoms. Always think about whether it's acute or chronic ANCA disease in the elderly. Always ask for urinary symptoms. And again, if you have systemic symptoms, so I was just on the consult service. We had a guy with sarcoid, cardiac sarcoid, actually got treated for cardiac sarcoid because he had some heart block. He came in for acute kidney injury because he had new, obstructing calcium stones. Okay, so you talk to him. His creatinine's like 2, and you talk to him. He says, "Oh, my creatinine was normal until a couple years ago, and then they told me I have an increased creatinine." So it turns out this guy had uric acid stones. He had a urine calcium excretion of about 150 milligrams per day, and you guys, usually for calcium stones, we want something less than 250. So he was doing pretty good. So that was his urine studies for stones back in 2017. He just had one in November. His urine calcium is 400. His serum calcium was 10.9. He's getting a little bit of vitamin D. So it could have been that these sarcoid macrophages were making that 25 into 125. He just crusted his kidneys with all this calcium. Probably has sarcoid kidney disease as well. So just some things that we should always kind of look for. And I think that I didn't get that in the beginning. The person was handed off to me, but just things we, like everybody, we always want to kind of readdress. We want to make sure that, again, it got CKD, may not be on the med list, but are you in pain? Are you taking any Motrin, Advil, Lupron, that kind of stuff? Are you constipated? Can you get some over-the-counter phosphate bowel regimen? So, they don't give them in for GI preps anymore. But if you're constipated, you can get these over the counter. So you can have what they call phosphate nephropathy. So these calcium phosphate crystals plug up, these are the tubules, they just plug up these tubules. It doesn't happen in you and I who have normal kidney function, but if you have chronic kidney disease and take these phosphate things, it can cause these rocks that occur in the tubules and cause acute and chronic kidney disease. Again, we talked about stones or some sort of chronic inflammation as well. So just things that we should be, especially as consultants, looking at. Okay, so what are the things that we can do? All right. So the first thing, you guys, is, does a person have metabolic acidosis? So when, again, we lose these nephrons, each remaining nephron has to try to just overwork and use these hormones to try to get rid of acid. So the 3 they use are endothelin, ammonia, and aldosterone. Okay, so when you crank those up per nephron, what happens is you get kidney fibrosis. All those things scar the kidney. So what we try to do is we try to give a little alkali. Okay, if we can give some alkali, then we think that, okay, we can stop fibrosis. All right. So this is just, again, a very small trial. So there's about 3 or 4 of these small trials. Okay, they're comparing no bicarbonate to bicarbonate in a few patients that have CKD. Okay, so in these people, they were given bicarbonate. In the red is those that got bicarbonate, went from 20 to 24. These guys kind of stayed around 20. Okay, and what happened to their kidney function? Okay, so again, this is months. So sorry, this is 2 years here. Okay, so this is, again, 2 years here. Here's mils per minute. Here's creatinine clearance. Here's the bicarbonate group that kind of stayed steady. And here's the control group that went down and down and down. Okay, now you might say, well, that's not really a hard endpoint. It's a drop in creatinine, but it doesn't mean that much. But they just looked at dialysis too. So about a third of the people that didn't get bicarbonate ended up on dialysis versus 6.5%. And these trials, again, not quite as dramatic as this, but really seems to show that, hey, if we treat acidosis, maybe we can stop that scarring of the kidney. Okay. Now, another thing I just wanted to point out, and this was just recently in 2020, it makes perfect sense. There was a group in Japan that said, okay, we're not just looking at the bicarbonate, we're going to measure a VBG. So they got venous blood gases on these people. So 1,000 people had their venous blood gas checked. And you can see so this is a venous blood gas of 732. So that's an arterial blood gas, like, let's say 736. So if they were low, if they had an acidosis and their bicarb was low, they had over a 2-fold chance of being on dialysis. Okay. But if their pH was okay, didn't really matter what their bicarbonate was. Could they have respiratory alkalosis? Could they compensate? So that was really an important thing. And I think that you guys, a lot of times we'll ask you for VBGs for getting, giving bicarbonate or not. And, it's not just for renal function. What if these guys were actually, they have a respiratory alkalosis? And you guys, for cirrhotics, they really have a lot of respiratory alkalosis. So we just don't want to overdo and give the bicarb and make an alkalemia worse. So again, important, the bicarb's important. We think it's good. Most of the patients that we have, they really do have an acidosis, but it might be good to check the VBG as well. All right, and this is just ways to give bicarbonate, different things that we try to give, 0.5 to 1 milligram per kilogram per day, lean body weight, and actually, baking soda at level teaspoon is like 50 milligrams of bicarb. So, you can always get some bicarb. Okay, so the next thing we're going to do is just go through a question, okay? So let's say your friend from medical school asks you to see your mother, 72-year-old woman with a GFR 49, an albumin creatinine ratio pretty good at 20 milligrams per gram. Her blood pressure is 133/82, and she has long-standing hypertension, and she feels spectacular, okay? So her exams otherwise unremarkable, no edema, nothing, but her sister had to go on dialysis. Her sister was a diabetic, and so she's really profoundly not wanting to go on dialysis with this GFR that's 49 mils per minute. So the question is, with the SPRINT trial and our blood pressure guidelines, should we add another medicine to try to prevent worsening kidney outcomes? Would you guys answer yes or no? You think getting her your AHA guidelines, blood pressure less than 130/80, will that be beneficial for her kidney? We think that if she's somebody that walks and does is independently living, that's what the people in the SPRINT trial were, that it might be really helpful for their cardiovascular disease. But did it really help their kidneys? That was another question here. Okay, so again, this is based on the SPRINT trial. Okay, and they use this Omron blood pressure technique. So kind of what we do is we kind of add 10. So adding 10 is like how the AHA gets the clinic blood pressure of 130 versus that Omron blood pressure that they took in SPRINT. Okay. So here you guys is just a bunch of studies, and they looked at GFR loss. And when your blood pressure is high, the thought is you lose a lot of GFR per year. Okay. But when you get kind of here, they kind of try to draw this line here, but is this line straight? Where's the cutoff? What's going to happen? And so again, this SPRINT trial was 120 versus 140. Okay, so are we going to see a benefit? Are we not going to see a benefit? What's going to happen there? And actually, you guys, I think that most nephrologists were actually a little bit nervous. Okay, that actually there might be worse kidney outcomes. The reason why we think this is the following, and these are just kind of a couple papers from the New England Journal, and just something where we call this autoregulation. Okay, so you and me with normal kidney function, here's our mean arterial pressure. Our mean arterial pressure, we have these ICU trials, can get down to 65, and you kind of do okay. All right, your GFR, at 65 or something, it's going to be pretty normal. But if you have chronic kidney disease, especially with chronic hypertension, where your kidneys are kind of used to this higher blood pressure, okay, are your kidneys going to be just as good as that? And so your thought is, well, here's means that are a little bit lower. You've dropped off here. You've dropped off here. So with people with chronic kidney disease, a MAP of 65 for their kidney function may not be perfect. And so we'll try to, ask you guys to push that a little bit sometimes. Take them off their antihypertensives if they've got acute kidney injury. Let them ride up a little bit, okay? So my fear was actually that you're going to have actually a lot worse kidney outcomes if you had that Omron blood pressure of 120. But in fact, what we see is it wasn't really too bad, okay? That basically the standard is that 140, the intensive is the 120. This is ESRD, or 50% decline in GFR. They both got worse at about the same degree. Now, the people with the intensive did have more AKI, okay? So there was more acute kidney injury. In general, the group did better. Those that had AKI, they lost that survival advantage. So just something to think about. We don't want blood pressure too high, but we don't have to have super controlled blood pressure for kidney disease. Now, again, thinking about their cardiovascular disease, that might be a little bit different, but it's not really going to help your kidney to be that low, okay? All right, I don't know if that makes sense. You guys, you want to let me know if I'm going too fast here, if I'm sounding like a maniac. We doing okay? All right. Well, I'll just take that as okay. All right, you guys. So here we have a 58-year-old woman, GFR 55, albumin to creatinine ratio is up 380 milligrams per gram. We want less than 30 as normal. Okay, so she's obese, and you do a secondary workup for hypertension, and you don't find anything. Okay, so her blood pressure is 158/90, pulse is 72, and she's on nifedipine at 120, losartan at 100, and chlorthalidone. So she's kind of max dose here. She's otherwise, exam's okay, doesn't have any kind of cardiac disease that we know of, at least not yet. Her serum potassium is 4.3, okay? So this might be, you guys, something where your internal medicine boards, this is like resistant hypertension. What would be the next best drug that you give? Would it be clonidine, spironolactone, or minoxidil? Okay, so I just want you to think about that. So you're on your 3 drugs. Resistant hypertension is ACD, ACE or ARB. C is a calcium channel blocker, usually nifedipine and amlodipine, and D is a diuretic. So you did that. What's the 4th drug you give if your blood pressure is still high? Okay, so I think the answer, you guys, is going to be spironolactone with this potassium. Now, if the potassium was like 5.8, we're probably not going to add spironolactone. Okay, but if it's 4.3, the next best medication is the spironolactone. So, guys, this is just a trial where they're saying, what's the 4th best drug? Okay, and so this was comparing clonidine versus spironolactone in 187 patients. Here's where you see the blood pressures. Here's spironolactone versus clonidine, the diastolic. Again, the systolic's here. There was a change. The winner was spironolactone. And there's other trials where spironolactone is compared to other drugs. It really is probably the 4th best drug, okay? So again, with spironolactone, you guys will see this with really bad heart failure. You want to try to add spironolactone to prevent fibrosis. You might see it with resistant hypertension. The 4th best drug is an aldosterone, a mineralocorticoid antagonist, okay? But what is the bane of this? And I think for both those trials, we know the problem is potassium. The blood potassium is high, okay? So we're not able to use this quite yet, but I think this is going to be coming down the pike, okay? So you guys, this is something called finerenone, okay? So finerenone is a non-steroidal mineralocorticoid receptor antagonist. So unlike spironolactone and pleuronone, it's a non-steroidal thing, okay? So it still has those anti-inflammatory properties, but for some reason that's really not clear to me, despite me asking their scientific people. It doesn't seem to give you as much hyperkalemia, okay? So this was looking at over 5,700 type 2 diabetics, okay, that has, pretty low GFR, as low as 25, various albumins in the urine. So, this was just to kind of say, okay, if they didn't have that much albumin, if they had retinopathy, we're assuming it's diabetic kidney disease. These guys, they didn't have to have retinopathy because they had a lot of albumin. So their primary outcome is looking at, those that reach kidney failure, a 40% decrease in their GFR, or a death from kidney cause. Okay, so in the blues finerenone, in the reds placebo, and you can see that for all the outcomes, okay, finerenone seems to win over placebo. Okay, so here's the hazard ratio of 0.81, 0.82, so about a 19-20% decline in those outcomes. Okay, now here's albuminuria. So here the thought is, okay, we're reducing albumin with finerenone. So we know that spironolactone will reduce albuminuria. Finerenone does the same thing. And finerenone was also shown to have better cardiovascular outcomes as well. So this is looking at the kidney outcomes, right? So this was looking at the potassium. So here's finerenone, okay? So you couldn't have that high potassium to get in here, but it didn't seem to increase it that much. Although more people had to withdraw versus placebo, it was about half as much as in that Rails trial where they used spironolactone for heart failure. So again, raise the potassium a little bit, might be something coming in the pipe, might be something that really helps for heart failure, for resistant hypertension, for patients with kidney disease. At least this is diabetic kidney disease. Okay? All right. So you guys, let's go to next. And I'm sorry I'm not here because I could actually kind of pull you guys. So here's a 60-year-old woman with diabetic kidney disease. Her eGFR is 60. Albumin to creatinine ratio is 350 milligrams per gram. Hemoglobin A1C is not optimal at 8. She has some heart failure. She's obese. That's her blood pressure. She has edema, and she's a VIP. And let's make you either whatever you guys are going to be, the PCP, the cardiologist, the endocrinologist. I'd love for a nephrologist to be in there, but probably not. But let's say you're one of these people that's taking care of the VIP, okay? So her medicines are metformin and lisinopril. And you're going to, she asks you as the VIP, what's going to be the best thing for my heart and my kidney? What class of medications would you use? The DPP-4s, the SGLT2s, or the GLP-1 receptor agonists? Which one of these groups is going to be the best for me? What is the newest data here? So you guys are probably going to pick the SGLT2 inhibitor, okay? So this is, and again, we're a little, I think we started late. So this is a pretty picture about how these things work, okay? But we're going to, again, look at SGLT2 inhibitors, okay? So I'm going to torture you with renal physiology, and I'm sorry about that. So you guys, here's the kidney lumen. Here's where the urine space is. Here's the epithelial cells that line it. Here's kind of the blood side, okay? So normally sodium and glucose, if you spill it, it gets reabsorbed by the proximal tubule, by this co-transporter, okay? And so what these guys do is they block it. So you basically pee out salt and sugar, okay? So you just kind of get rid of that extra sugar, you're peeing out salt as well. It's found to be, in animal studies, something that cuts back on TGF-beta. That's always a bad guy. That's a guy that scars things and seems to cut back on inflammation, okay? So could this help out with cardiac and kidney disease, okay? So I think it's really been shown that for patients with cardiovascular disease, it's really a winner, okay? Now this trial using canagliflozin was trying to look specifically at kidney outcomes in type 2 diabetics. So we got placebo versus canagliflozin in type 2 diabetics. GFR is as low as 30, and here's the primary outcome: dialysis, doubling the serum creatinine, or death from renal or cardiovascular causes, okay? So what happened in these patients looking at kidney outcomes? And what you can see is, in the blue, that whatever outcome you pick, canagliflozin is better than placebo, okay? So the renal outcome was reduced by 34%, dialysis by almost a third. I mean, really, this is something that's spectacular. We haven't had anything like this, okay? And one of the things that I just, again, want to kind of reinforce to you is that we may not see these people until stage 4, stage 5, where their GFRs are less than 30. You guys are going to see them. You might be in cardiology, they might have a little bit of heart failure, you might be in endocrinology, you might be primary care. You're going to see them beforehand. So do we start this a little bit earlier for those people who are fading, or do you need to run them quickly into us? Like, this is really an important thing. I think this is thought to be the game changer for patients with diabetic kidney disease, okay? All right. So just a little bit about torture about how this works. Okay, so here's the glomerulus, okay? And blood comes in here, the afferent arteriole, goes through the glomerular capillaries. Here's where urine's made, and then it goes out the efferent arteriole, okay? So normally, you guys, what happens is, if you have a lot of sodium chloride coming through here, okay, so you have a high GFR, you make this filtrate, you have all this sodium chloride here. If you've got a really high GFR, this is a signal that says, whoa, you're going too fast. You need to brake, because if you have this high a GFR, you're going to blow away these capillaries. You're going to cause a problem. So if you have a high sodium chloride delivery here, okay, where the loop is, you actually have this brake, and you cut back on the inflow here. You decrease the GFR, okay? So I want you guys to think about this, okay? So let's say we just have someone with AKI because they're either dry or, sepsis or something like that. Their pressure's low, okay? And we're just running the sodium chloride in there, okay? So if we're running the sodium chloride in here, what's gonna happen is we're gonna cut back. We're gonna actually close this off. And that's something where we really might not wanna do. So that's why there's this sort of thought that, hey, instead of giving just sodium chloride, let's give balanced solutions. Let's give lactated ringers, okay? So that's kind of the opposite situation. But for us, with diabetes, what happens is that insulin growth factors actually rev up the GFR, okay? And the other thing, again, is that you've got this sodium glucose transport here. So if you're spilling glucose, what'll happen is this thing will suck up sodium and glucose, okay? So then what'll happen is that, again, you're thinking that, you know, there's not that much sodium chloride here because it goes this way and then comes back up and loops around this way. So if you're sucking up with this sodium chloride here, you've got the lower amount here. So if you had a higher amount, remember you braked. But if you have a lower amount, you'll let this go. They're already hyperfiltering. They've already got too much insulin growth factor. If they've got chronic kidney disease, again, there's more blood getting to these things. So you are not helping the hyperfiltration. In fact, you're letting it go by sucking up sodium and glucose here in the diabetic, okay? So what the proposal is, and again, sorry, I'm a little slow with this. What the proposal is, hey, if you block this guy with this SGLT2 inhibitors, if you stop that sodium glucose getting sucked up there, then you'll actually, again, deliver more here, deliver it more here, and then you'll go, okay, I can't pee so much, you know, I'm going to pee myself to death. So I need to cut back here, cut back on that GFR, reduce the hyperfiltration, okay? So it's a way of kind of, again, just reducing the pressure when there's too much pressure in a diabetic who might be just, again, a lot of the blood, all the blood now has to go to those remaining nephrons. How do we kind of spare those nephrons, okay? All right, so just again with SGLT2 inhibitors, from glycosuria, we're thinking there's weight loss, there might be less epicardial fat. We're going to reduce the hemoglobin A1C, we're going to reduce inflammation, hopefully help with atherosclerosis, okay? From that, just again, we're blocking sodium glucose transport up. It's kind of like a proximal diuretic. So we're decreasing plasma volume. Again, we're kind of reducing that hyperfiltration, reducing blood pressure, and all these things will help with our myocardial stretch. We're not going to be so blown up. Our heart's not going to be so blown up, and our kidney's not going to really feel all those high capillary pressures. So again, this is a way that these guys really may help with both heart and kidney disease, okay? All right, so let's say you've got your VIP, right? So she comes in there and you start the SEOQ inhibitors, okay? And she gets labs a couple weeks later, okay? And her GFR goes from 60 to 55 after 2 weeks, okay? And then the question is, what do you do now, okay? So you're panicking, okay? Do you stop the inhibitor or you keep the inhibitor and recheck the labs, okay? So what you did, you just lost 5 mils per minute of GFR, okay? You got a VIP, okay? So what she's gonna say, well, what's with my labs and things like that? So remember what we did? We reduced that hyperfiltration, okay? So in other words, your GFR is expected to go down. So traditionally with these guys, you see a drop of 5 mils per minute very, very quickly. But in the end, looking at this is 42 months. In the end, what happens is you drop it here, you pay me now, but I am going to be better later than if nothing happens, okay? So again, it's this sort of flattening out after that initial drop. So what you want to do is, you know, if it's 5 mils per minute, you want to hold tight, check it again, but if it stays at 5 mils per minute, you're good, okay? If it's 5 mils per minute and then 10 mils per minute, then 50, you know, then there's some problem, okay? But at first, that's the expected thing to happen. That's like adding an ACE inhibitor for patients with chronic kidney disease. We might see an increase in creatinine at first, okay? But then we are expecting a leveling off. All right. You guys, this is again, just albuminuria will reduce as well, reduced by 31% here. Okay. You guys, just things that you should know if you're going to start these, if other people are going to start these. So if you got a diabetic, let's say he has a neurogenic bladder, he's got a lot of UTIs, and now you're putting this guy and you're giving him something that now puts sugar into his bladder. And he's got a neurogenic bladder, so it just sits there. So, you know, you got to just kind of know that these people probably were not, a lot of these people were not on the study drug, okay? So initially there was, you know, a lot of, I'm sorry, not a lot, but there was urosepsis, pyelonephritis, there's this sort of diabetic ketoacidosis in a type 2 in people that are, just odd. Their sugars are not that high. There's cases of AKI, but in the trials they didn't see them. And is that because when you're in a trial, you're seeing a lot. You get a lot of follow-up. People are asking you about these things. You get a lot of follow-up, a lot of labs and things like that. Or is there sort of like no drug's perfect? I think it's probably, I'm not sure that this is going to happen a whole lot with these AKI cases, because I think people know a little bit more. Oh, I should be checking things. I should be rechecking things. But just, some things to think about. In all studies, there's more genital infections. Okay, so what about non-diabetic chronic kidney disease? Okay, so this was using dapagliflozin in 4,300 people. Okay, GFRs are pretty low. Okay, and 2/3 were diabetic, but 1/3 was not diabetic. Okay, and again, looking at the outcome of, this is mostly kidney outcomes of reducing the GFR by 50%, being on dialysis, death from CV or renal causes. Okay, so again, this is just, here's cardiovascular cases, heart failure. Again, we kind of see the same thing. Now remember, 2/3 are diabetic, 1/3 are not diabetic. Okay, so this is death from any cause. Again, the dapagliflozin seems to win. Okay, here's kidney outcomes. Again, the dapagliflozin seems to win. Okay, so one of the questions is, well, was it different between the diabetics and non-diabetics? Because again, we're kind of saying, oh, you block the sodium glucose transporter, you're doing all this stuff. If you're not diabetic, why would this work? Okay, so again, in non-diabetics, again, the hazard ratio was actually a little bit better than even the diabetics. Okay, and I'm not sure we fully know why that is. One of the thoughts is that all these sodium transporters in the proximal tubule, they kind of might all be linked. So that if you block one of them, that sodium glucose transporter, are you blocking other ones where you're not reabsorbing sodium a little bit more? It's kind of like a little bit of a diuretic. Is that what's happening? Are we reducing, again, that hyperfiltration in a little different manner? Because you're putting a little bit more sodium out there. Not quite clear, but again, as a nephrologist, I'll take it. If something's going to work, I'll definitely take it. Okay, so guys, we're kind of coming around the bend here. Okay, so here we have a 60-year-old guy, eGFR is 45, had a cabbage and was placed on a PPI. Okay, so what are we gonna do with PPI? Okay, so are you having any symptoms? No. Why are you on it? Because I'm always on it. I was always on it since my cabbage, so I'm on it. Okay, so the question, you guys, is, do we just kind of keep it, or do we take it away if he has no symptoms? Okay. So you guys, this is just a sort of, again, a cartoon about GFR, just time, and how there's sort of this steady decline in GFR over time. As we, again, sort of, you lose nephrons, the other ones try to make up for it, and just through time, you're going to lose GFR. Okay. But this is what tends to happen. Okay. So we tend to give medicines, okay, calves, are we going to diurese people? And that tends to accelerate the course of getting to dialysis, okay? So, I would just say at Georgetown, instead of gentamicin for UTI, which we don't really do, are we giving a PPI and keeping it on forever? Okay, who do we see in the medical service? We're seeing these cirrhotic guys, okay? So they're getting lactulose, they're getting diuretics, again, their blood pressure's low. So, we're kind of given this AKI on top of maybe CKD, okay? So, one of the things that I want you to know is that your chance of getting AKI is really a lot higher when you have chronic kidney disease. Remember, your ability to autoregulate, your ability to tolerate that low blood pressure, it's much worse with chronic kidney disease. So you have this tendency to have AKI. Every time you have an AKI, especially if it causes tubular necrosis, before, you might have had 100% of your nephrons, but if you only have 50, and now again, you damage, the problem is, again, every time you have AKI, you worsen CKD. So it's this cycle. So the idea is, if you could, is to try to prevent AKI, okay? So guys, this is just interstitial nephritis, okay? So it's allergic interstitial nephritis. PPIs are the most common cause of interstitial nephritis. And this is what we love to see all the time, okay? So up here on the top left is your maculopapular rash everywhere. These are white cells, and these are white cell casts, and you send for urine eosinophils, and lo and behold, you see these urine eosinophils. So one of the questions is, how often do you see this, constellation of symptoms with PPIs, these allergic symptoms? And you really don't see it very much, okay? So you guys, a lot of times it's drugs, and just because you don't see those white cells, white cell cast, that rash, that fever, just doesn't rule it out at all, okay? This is just another review where they're looking at methicillin, where methicillin, really there is a lot of pyuria, hematuria, extrarenal symptoms, eosinophilia. Here's every other drug. It's like 50-50, okay? So I always think if I see something, especially chronic kidney disease, AKI, is it some drug that I'm not looking at, or I'm missing here, okay? All right. So again, just kind of sitting down out here. So guys, this is just, besides that, this is again, just what people will say, there's chronic kidney disease that's been really linked to PPI. Some people will say, well, the substrate of the people is, they might be obese, they just might be of the substrate of people that are going to have chronic kidney disease anyway. So what people did was they took these, very large cohorts of people, and they kind of compared, okay, let's see the difference between people who take PPIs versus people who are on H2 blockers. Okay, so is there a difference? Because the population is about the same. What they found was that, basically using a PPI still gave you more chronic kidney disease than someone who's on an H2 blocker. Is it doubling? Is it threefold? No. 40%, 30% increased risk, something to think about in these large cohorts. And we really, again, this is just, I think we can just, this is basically taking people, okay, looking at ESRD or 50% decline in GFR, and they looked at coding and they said, okay, was there ever an AKI? So, maybe there was an allergic interstitial arthritis, and, it had nothing to do with PPI. But what they did was they, again, kind of did this, took out codings and said, look, was there a difference? And in fact, again, here in brown were the PPIs versus the H2 blocker. So again, it seems like a little bit more with the PPI than other things. And then we really don't know why this is, okay? So, we know it can alter the gut flora. People are really big into now the microbiome and inflammation. And if you screw that up, are you kind of worsening kidney disease from that? Magnesium, so low magnesiums, is that inflammatory to kidney and endothelial cells? Is that a problem? And so, there's speculation, but I don't think we can ignore it as a link, okay? All right. So again, just again, with people with chronic kidney disease, if we could try to avoid low MAPs to prevent the AKI, which and then causes worse CKD in the interim, because you just can't recover. Something that I'd really like you to try to think about, okay? So our take homes are just to try to recognize CKD. And if you guys, there's a referral, it's great to know what is that albumin to creatinine ratio, okay? That really kind of can tell me, oh, that person, if it's high, they could really progress fast. And I'm really worried about their cardiovascular disease, okay? So, our blood pressures, we have to kind of think of the whole person. So if you've got a really healthy person, to try to shoot for that less than 130/80, knowing that it really may not help your kidney outcomes. You don't want it to be 150, but 130, I think that that's a great compromise. If they have a bicarb that's low, bicarb's pretty cheap to give. If they were diabetics with a GFR greater than 30, I would really think about SGLT2 inhibitors. And even if they're not, okay, to think about that as well. And then again, we might have this new mineralocorticoid receptor antagonist that may not give a hyperkalemia as much as spironolactone and eplerenone, that you guys know will be great for fibrosing or reducing fibrosis in cardiovascular disease. And it looks like kidney disease as well. So if something, we could give that and not give hyperkalemia, because remember, they're all on ACE and ARBs, okay? That would be great. And I'm sorry, I forgot to just mention one thing with that, okay? So we talked about people, especially the ones with a resistant hypertension. And I'm sorry, I'm going backwards. I should have remembered this before. So you're on an ACE or an ARB. Why, you're blocking aldosterone. Why would giving an aldosterone inhibitor do anything? Like, why should it do that? Like, you're already doing losartan. Why would you get any aldosterone? Well, it turns out that from 10 to 50% of people will have what they call aldosterone breakthrough. Okay, and so basically, even though, what you'll do is you'll measure their aldosterone levels before they get an ACE or an ARB, and then afterwards you'll measure them, okay, and then some people actually have an increase in that. So, how that happens is unclear, and I can't get a good, just overall, these are the people that get this. It seems to be people with more albuminuria. But other than that, I'm really not quite sure why some people get this, but there's definitely this breakthrough. So adding this aldosterone antagonist for all the reasons we talked about, for heart fibrosis, for bad hypertension, is it that there's these other pathways for making aldosterone, that these new mineralocorticoid receptor antagonists, and even the old ones are good, okay? And again, just trying to avoid AKI in chronic kidney disease.